we're now going to talk about the concept of effect measure modification. I like talking about effect measure modification after discussing and sharing clearly the concept of confounding, so that people one can appreciate the two and not confuse them. So while we're still looking at other factors, we're still looking at validity, we're still looking at how to measure exposure outcome associations and how best to report the findings and how to best to interpret those findings. And this is the concept of effect measure modification. Now, we appreciated a confounder as a factor that is outside the main exposure outcome association, that is trying to interfere with our exposure outcome association by being here related either causally or non-causally with the exposure in the population, but also being an independent risk factor for the outcome, therefore confusing this exposure outcome association unless measures are done to adjust for it. In other words, we aim at looking for these factors and then we adjust for them so that we report an adjusted exposure outcome association as either an odds ratio or a hazard ratio or whatever it is when it is adjusted for potential confounders. So we look for confounders in order to adjust for them and get a valid or precise estimate, a more valid estimate of our exposure outcome association. That is confounding. Now, when it comes to effect measure modification, the third factor, again, is doing something different to our exposure outcome association. What it is doing actually is that instead of giving us one uniform outcome, like exposure outcome, we instead get a split outcome. I like to call it a split. Our exposure gives us, let me give an example of two. Instead of giving us one uniform outcome, or it gives us two small outcomes. Two different outcomes, let me say. Okay? It splits along the way and does not give us the single uniform outcome we expect. People who are exposed to outdoor jobs don't all just get malaria. A certain group will get a lot of malaria, a certain group will get no malaria. Same population, two different subgroups within that same population. Instead of assuming that everybody gets malaria because they have an outdoor job, instead you find that having an outdoor job and getting malaria depends on a third factor. Now, this third factor is not a confounder, it's an effect modifier. In other words, it modifies or changes this effect. Instead of getting one uniform effect here, we get a changed effect by the third factor. Now, this third factor here, I don't know what letter to use. Let me use the letter Z for our effect modifier. If our third factor, if we go back to our example that we used of gender, this could be the factor sex. So among males, we are getting a different outcome. Among females, we are getting a different outcome. In other words, if your question is, does exposure to an outdoor job lead you to getting malaria? The answer is it depends. It depends on whether you're a man or a woman. The third factor is sex. So it does not confuse or confound the exposure outcome association. It splits it, it changes it into two different effects, such that you cannot report one single effect. Your answer, your effect will be, it depends on, if you're a man, the effect is this. If you're a woman, the effect is this. Okay? That is effect measure modification. And by name, we know that by name, it has changed the overall effect. It has modified it by levels of a third factor. Just like a confounder, those levels would depend on the nature of that third factor. If we give an example of sex, we could only have two categories, either you're male or female. But if we looked at another, if the effect modifier was age, we could have multiple age categories. It means it could split this effect by the 3 or 4 or more different categories, such that we have like 3 or 4 different outcomes. We could say the ones less than 5 years, we have a different outcome. The ones that are teenagers, 15 to maybe 20, we have a different outcome. The ones above 35 years, we have a different outcome. So we shall have 3 different effects. So what is expected to be like an overall effect cannot be, is no longer relevant, but the effect it depends on your age. If you're less than 5, this is the effect. If you're 15 to 30, this is the effect. In other words, you can't get this effect when you're this age. It depends on what? The level of the third factor. So the effect of the exposure on the outcome has now been modified. That is in brief the concept of effect measure modification. So when a relationship between a given exposure and a given outcome varies or changes across subgroups of a third factor or across strata, sometimes we use the word strata, but we could also use the word subsets, we could use the word subgroups of the third factor. That is the concept of effect measure modification. Okay? Now, in that situation, the overall effect, the crude, the exposure, the single outcome is no longer useful, is no longer an important measure. Okay? It does not give us the adequate picture of what's happening in the population, because the truth is, this one will be like an average of everybody. But what is actually happening is that we have a given population which has 3 subgroups of populations. Some at very high risk, others at moderate, others are free of risk in that same population. So if you're measuring effect, it's going to be, it depends which subpopulation, which subgroup are you looking at. Are you looking at the younger ones? Very high risk. Are you looking at the midway ones, teenagers? No risk. Are you looking at the older ones? Some risk. So the answer, is there a risk of malaria? With outdoor jobs, spending the time outdoor, it depends on your age. Okay, that is effect measure modification. So usually people, when they find confounder, it's like you probably didn't look for it, you probably didn't measure it accurately, you probably did not adjust for it. Now for the effect modification, it is not a factor to be adjusted for. Instead, it is a phenomenon to be discovered and reported as is. So when we find that there's confounding, we're supposed to have measured the confounder accurately, we're supposed to have adjusted for it to remove the effect of confounding. Unlike confounding, for effect measure modification, we do not remove the effect. Instead, what we do is we report it if it exists. We no longer report this overall crude effect, we report the subgroup effects that are happening because of the phenomenon that has been realized to be existing. Okay? So, once we have a relationship between a given exposure and an outcome varying, not being uniform, it is varying by the subgroups of a third factor. That's effect measure modification. Okay? So, in other words, we are now asking the question, what is the effect of a given exposure, E, on a given outcome, D, or O, as I prefer to use? The question is, what is the effect of E being on outdoor job all the time and getting malaria as an outcome? And the answer will be, it depends. It depends on whether you're a man or a woman. Should you be a man? Very high risk. Should be a woman? No risk. Okay? These are some of the examples that we have here to demonstrate this effect. Risk of HIV acquisition from infected partner per sexual act depends on whether you're a man or a woman. Very high risk if you're a woman, because of a higher exposure surface area, very much lower risk if you're a man. So the effect cannot be uniform in people. And then before someone gives you an answer, they say, tell me whether they're asking about a male population or a female population. Then I'll tell you that the risk is high or is low, because there is a phenomenon there operating to influence risk of HIV acquisition per sexual contact. Second example, effect of motorcycle riding. And I'm looking at different areas, aspects of epidemiology. Clinical, the social epidemiology, the health service research kind of epidemiology, all that is applicable. The same concept, the same phenomenon operates. Effect of motorcycle riding on fatal accidents. What is the chance, what is the likelihood that a driver riding a boda or motorcycle related accident will die because of that accident? The answer is it depends. It depends on whether that driver was wearing a helmet or not. Why? Because most of the death occurs if someone gets a head injury. The kind of accident a boda man will get when they are riding a motorcycle, if they do not get a head injury, they are likely to die from that accident. They may break a limb, they may break a leg here and there, they may smash something, but they are not likely to die. If we are looking at death, what is likely to cause death? Head injury. Therefore, what is the effect of getting death when you're involved in a motorcycle accident? Were you riding with a helmet on? Before I give you the answer. Therefore, helmet use modifies the effect of death while riding a motorcycle once you're involved in an accident. If you're wearing a helmet, chances are low, risk is low, the effect is lower. If you're not wearing one, effect is very high. That is another example. Third factor, effect of intermittent preventive treatment of malaria on preventing malaria depends on how much infection is in the background. Confusing this with insecticide treatment. Intermittent preventive treatment. We give treatment for anti-malaria to prevent malaria at intervals before people get malaria. So if you're going to prevent malaria by giving anti-malaria drugs to a healthy person to prevent them from getting malaria, are they likely to get malaria anyway when you actually prevented it with drugs before? The answer, it depends on the background force of infection. If they're the type of people living in an environment, they're being bitten by mosquitoes, 5 to 10 mosquitoes every second, chances are high they'll still get malaria even if they are taking the preventive drug. Are they the people in an environment with very few mosquitoes in the background, force of infection is low? Likely to be very low chance. So in other words, before the prevention of malaria works to actually prevent malaria, it depends on the third factor, which may be an effect modifier. If you're gathering information on whether someone is taking the preventive treatment and gathering information on whether they are getting malaria, you need to gather information about the background environment where they are living. And then check to see whether this factor is modifying this effect of preventing treatment from getting malaria. Is it modifying it or not? If it is modifying it, you report the two different effects that are happening. Because remember that our effect modification is the split effect. It is a modified effect. We no longer have an overall effect. There is a third factor that gives us a split effect. Outcome 1, outcome 2 that are different. And those two will depend on the third factor. So if this mechanism is occurring, you're going to report to us these two effects because they're the ones we're interested in. If there is no effect modification, you're going to report to us the single E-O association. In other words, whereas for confounding, we look for it and adjust for it, effect modification, we look for it, and if it is present, we report the results as are. We report the different layers of effects that have been modified. We do not adjust for it to remove it away. It is not a mechanism, it's a mechanism. It is not a spurious or confusing effect we remove the way we remove confounding. It is a phenomenon, a mechanism occurring. It's an inherent effect of the exposure outcome pathway. So you have to report it as it is, as you have observed it, if you have observed it to be present. So, cryptococcal meningitis, being exposed to this small yeast and getting meningitis because of that small yeast, what is the chance that when you get into your bloodstream, into your system, this yeast, cryptococcus, you're likely to get a meningitis? The answer is it depends on your HIV status. If you're HIV infected, you're likely to get that meningitis. Very high risk. If you have no HIV, this yeast will never cause you disease. HIV modifies the effect of cryptococcal infection on meningitis. So you cannot report that effect without telling us the HIV status, because the answer depends on whether or not the HIV is present. Now, we have seen and appreciated the concept of effect measure modification. How then do we evaluate it using the data? Okay? How do we evaluate it using the data? I'll give an example. You are looking at, a lot of studies look at vaccine efficacy, because we know that vaccines prevent disease, and in public health it's very important that we look at effects of vaccines. Each vaccine that is manufactured, before it is passed and approved for use in the population, we look at a measure of epidemiologic measure, which is its efficacy. By how much does it protect people? By how much will it prevent what it is intended to prevent? It could be a cholera vaccine. It could be, right now we have newer challenges. We already have the cholera, we have the polio, we have the rotavirus vaccines. We now have new emerging infections. We have Ebola, we have Marburg, and we're looking for vaccines for those. So vaccine efficacy becomes very important. So this table just shows us the vaccine efficacy. It's looking at the status, whether the child, a relationship between having received the vaccine or not having received it, and the cases of disease. This could be measles, could be any childhood disease that is vaccine preventable. Could be hepatitis, could be pneumonia, could be TB, could be anything. So, this is the population, number of cases, and we know that among those vaccinated, this is the total population of the vaccinees, but these are the people, children who got measles, 150. So the number of cases per 100,000 is a fraction of this divided by this, which gives us 0.49. Then therefore, out of these cases per 100,000, if you compare it with the cases who get these measles but we are not vaccinated, we get this fraction. These two fractions give us a relative risk of 1.28. 0.28. In other words, the protection. So the vaccine efficacy is 1 minus the relative risk, which is 1 minus the 0.28. So the effectiveness, which shows the effectiveness, the positive impact of the vaccine, is measured as a vaccine efficacy, which is 72%. So if you just go in a population, conduct a study, don't care about other factors. You just look at the population, look at the people who got the vaccine, look at the cases of measles, take your measures, you're likely to get a vaccine efficacy of 72%. You say, good, this is good enough. This vaccine, once you roll it out into a population, it will prevent measles in 72% of the population. So, well, how about this? If we split that population by age, what then do we get? We split that population, same population, by age. We are looking at the age under 1 year, whether vaccinated or not vaccinated, the total population, those cases of malaria or measles, our number of risk, proportions of measles per 100,000, per 1,000 population, relative risk, and the vaccine efficacy, just like we did. We now have 1, 2, 3, 4, 5 measures of vaccine efficacy that are different. Here, we had one, because we didn't look at population age. We just measured overall 7-year-old, 2-year-old, 15-year-old, and our vaccine efficacy showing us to be 72%. Here, we are looking at 4 groups. We are looking at under 1 year, 1 year to 4 years, 5 to 9, 10 to 24, and more than 24 years. We have 5 age groups. And we have here, equally, 5 vaccine efficacies. And if we look at these vaccine efficacies, the impact of the vaccine on preventing measles, we can see that in those children who are less than 1 year of age, only 13% of them are protected, even if they receive the vaccine. For every 100, only 13 get protected. The following year age group, 1 to 4 years, the other 5, only 58% are protected. 42% still get the measles. We move to the 5 to 9 years, 81% are protected. We move to the 10 to 24 years, 85% are protected. This is likely not to be a vaccine of, and you move above 24 years, it lowers down to 60. So, what is the vaccine efficacy? It is different depending on the age of the individual in the population. In other words, the effect of the vaccine on preventing malaria depends on the age, in any population, depends on the age of the people in that population. The effect can no longer be stated as 72%, that is average, cannot be averaged as 72%. It can only be shown that there are 5 different effects. In one group is only 13%, 58%, 81%, and 85% in this group, and then it's low. So in other words, you may not, as a public health person, not required to vaccinate everybody in that population, just roll out using public health dollars or shillings, and you give a vaccine to everybody, including under ones who only have an efficacy of only 13%. So in other words, effect measure modification, it is a phenomenon to be discovered and reported as such, and it has a strong public health application. A good classic example is here. If you only have little money, who will you choose to vaccinate in a population? You're likely to choose the 5 to 9 and the 10 to 24 year age groups to be the ones to receive the vaccine. Reason being, there is maximum benefit if you vaccinate only these. And if you do not have all the money to vaccinate everybody in the population, you will prioritize. You prioritize and say, let's vaccinate these ones. These are the ones likely to benefit from the vaccine. The next group that may benefit if you have some more money, maybe the elderly, the ones more than 24 years. These ones, you're likely not to vaccinate under ones. Because for every 100 you vaccinate, and vaccines also have their own side effects, only 13 are likely to benefit. Okay? 87% 87 children will not benefit from the vaccine, and yet you spend a lot of money on it. So you want to choose where the vaccine is the maximum. That is the phenomenon and the application. We jumped a little bit. Application of the concept or phenomenon of effect measure modification. Okay? So we noted that there is a difference in vaccine efficacy across subgroups of a third variable. The third variable here is age groups. In other words, the impact of the vaccine on preventing disease is modified by age. That is effect measure modification. And it has clinical and public health action based. If you take public health action based on the other summary measure of 72%, you're likely to just roll out a vaccine and vaccinate everybody. But then you now know you're not being cost effective. You're not setting the right priorities. If you're going to vaccinate a few people who are likely to maximally benefit from the vaccine, albeit with comparison to its safety and side effects, tolerability, then you're going to look at the subpopulation where there's maximum impact, where there's likely to be maximum benefit. So you'll have applied the concept clearly. Okay? What is wrong with the summary measure of 72%? It hides essential information. It hides essential information. If you just roll out vaccinate everybody, you will not know that the vaccine won't help the newborn, yet the newborn will go ahead and get injected. You may not have enough money and you say, let's defer this program of vaccination. We don't have enough money to vaccinate everybody. But then in that population, there is a group that will benefit. There is little money, let it vaccinate the group that has maximum benefit first. So you will set your public health priorities accurately. Okay? So another quick example, you have an individual who is 140 centimeters tall. Another one is 200 centimeters. Another one is 170. There's always variability of height in populations. You are trying to measure their average, if you average them, comes to 170. If you order uniforms for the three of them, it is likely to fit only one person, the one weighing, the one with a height of 170. That average will not fit the one of 200, it will not fit the one of 140. So, the thing is, whose uniform is this? It depends on the height. That is a concept in simple terms. So, let's go a little bit back and compare confounding with effect measure modification. What happens to a population? What happens with studies? What happens with phenomenon as we're doing studies? You measure your crude. We've evaluated effect measure modification. We've evaluated confounding using the data. What do we do then? We look at the crude measure, which is the unadjusted measure. We measure it. We go down to the we go down to the stratum specific measure. These are the two subgroups of the variable. The crude, the unadjusted one, which we called the average, gave us a measure of 2, measure of association. The subgroup of the third factor is giving us 1.1, and the second subgroup is 1.2. We compare, as we said, between the two subgroups, 1.1 and 1.2. Are they similar? To me, they are. Once they are not more than 10% different, they are not different, and that is the rule of thumb. Once they are more than 10% different, we declare them different. So 1.1 and 1.2 are not more than 10% different. Therefore, we consider these to be similar or homogeneous. Then we move to the next level and compare these with the crude, the unadjusted one. It is 2. 2 is different from either of these. Therefore, there is confounding. We move to do our Manto-Henzo adjusted measure, and we report this one, which is an adjusted measure. That is the concept of confounding. You present this one. Now, what about in the presence of effect measure modification? You do the crude, it is 2. You go down to the strata, the subgroups. Remember, effect modification, we say, is a split effect. The effect is split is in 2 different effects. In other words, there is no homogeneity, there is no similarity of effect. That is why we refer to it as effect modification, effect change, if I may borrow that word. 2 different effects. It means in one subgroup we have a different odds ratio, in another subgroup we have a different odds ratio. We come back here. Here it is 1.1, one subgroup. The second stratum or subgroup has 3. 1.1 and 3 are considered to be different, simply because even quantitatively, they are more than 10% different. Unlike this scenario of 1.1 and 1.2, these are approximately similar, but different from 2. Here, when we compare these two, 1.1 and 3, they are different. So while here we say there is similarity, and we say the word to use is homogeneity. There is homogeneity of strata. Here, there is difference. The effects are different. Here it's 1.1, here it is 3, triple. The risk triples. Here is the concept of heterogeneity. There is heterogeneity of effect, and this is the effect modification. Now, in the presence of these, what do we report? We report these two. Okay? So you present both. What is the effect? It depends. In stratum A, it is 1.1. In stratum B, it is 3. Okay? Here, you present, in presence of confounding, you present the adjusted measure, which is an average of these to remove the confounding. Here, you report, once you find confounding is present here, you adjust for it and report this one which has removed it. Here, the purpose is not to remove effect modification because it is not a phenomenon to be removed. It is a phenomenon to be discovered and reported as such if it exists. If we discover that it doesn't exist, we report this. But if it exists, we do not summarize. We report these two because they are two different effects that are happening. These are two different mechanisms that are happening. And that is how the concept of confounding differs from the concept of effect measure modification. This is again the same concept diagrammatically. We are looking at single parent family and the income of that family. When you look at this, you look at, oh, okay, for single parent, hey, it is good. So once you have a single parent family, the income keeps going up. You say, hey, this is good. When you come down here, you say, oops, what is going on? The effect has been shifted, has been modified and changed by gender. This little arrow means male, this little arrow means female. Once the single parent family is headed by a woman, the income tends to be lower and lower. Once the single parent family, it is a man heading it, the income goes up. So they are taking two different directions, depending on whether that single parent is a man here or a woman. So what is the effect of single parent headedness as a house and the income? It depends. If you average it here, you will not see this effect. Now, directionality of effect modification. Just like confounding, we have positive, negative, and qualitative confounding. So do we have positive, negative, and qualitative effect modification. The other term that we use for effect modification is interaction or heterogeneity. All those terms is just epidemiologic jargon. Each scientist kept on discovering the phenomenon and giving it slightly different name, same meaning, same concept, same idea. So, positive interaction. If the presence of interaction increases, if the presence of the effect modifier results in a stronger or a larger measure of association, this is synergism, another word again. Okay? It is enhanced, in other words, it is positive. It is synergistic. When the third factor came on board, the effect went up. Just like the factor of gender, when it came up, income went up for the man. This is synergism, positive confounding. When the factor came up and it is a woman, income went down. From this average, it went down. This is negative interaction. When income interacted with the sex of the household head, the income goes down. If it is a woman, this is negative effect modification. It is negative interaction. It is antagonism. All those terms mean the same thing. Here, it is synergistic. It is synergism. It is positive interaction. It is positive effect modification. When the presence of an effect modifier results in a weaker effect, it is antagonism. Qualitative one is when there is a change of effect. Again, just like the concept of confounding, once there is a change in direction, it becomes qualitative. So I want to look at this in terms of the numbers to appreciate how we can evaluate this in stratified analysis. Once you have a crude odds relative risk of 3.1, you split it by the strata, and the relative risks you get, the two subgroups, one is 3.2, one is 3.3. These two seem similar. 3.3 and 3.2, they are not different. And they are also not very different from the crude one, it's just 3.1. Here, you conclude that there is no confounding. In other words, if the stratum specific estimates are similar, as we've seen here, 3.2 and 3.3, and are all similar to the crude, there is no confounding. But if they are similar, but they are different, they are either bigger or smaller than the crude, that is when there is confounding. We have an example here. These two, the two substrata, are almost similar. 3.2 and 3.3, two strata, similar almost. The crude is now 1.9. These two are similar but different from the crude. There is confounding. There you have to report the adjusted measure. Okay? Or they are, in this case, these are both different, but they are bigger. This is only 1.9. This is 3, and this is 3. 3.2, 3.3. So these two are way bigger than this one, the crude. In other words, if the adjusted one falls in these two ranges, it is likely to be bigger than this crude, this confounded one. This is a concept of negative confounding. Why? The truth is bigger than the confounded one. The confounding dwarfs or makes the true effect smaller. If you do not adjust and you take this crude, you report 1.9. But the truth is that the effect is 3 point something. So it is negatively confounding it. If on the other hand, you still have this crude of 1.9, but the strata fall down to 1.1 and 1, the crude is bigger. It means if you reported the crude, this confounded one, it would be an exaggeration of the true effect. The true effect is only 1.1, but you're reporting 1.9, which is almost 2, which is almost double. This one exaggerates. This is a positive confounder. So using these numbers, we can always measure and evaluate with the data the presence of positive, negative, or even qualitative confounding or qualitative effect measure modification. Same idea. You have two strata. The key thing to look at here for effect modification, which is different from the confounding effect, is the homogeneity of strata. These two RRs, the split ones, 3.2 and 3.3, once they are similar, there is homogeneity, there is no effect modification. Now you'll evaluate whether there is positive, there is confounding. You'll evaluate whether there is confounding or not by comparing them to the crude and looking at the value of the number. Was it becoming smaller or bigger? Then you determine presence of confounding, and you also determine whether the confounding is positive or negative.